everyone. My name is Meghan Mardashti, and I'm one of the AOCPMR's Multimedia Committee co-chairs and your host for today's episode. Joining us today is the esteemed Dr. Cindy Ivanhoe. As the Director of the Spasticity and Associated Syndromes of Movement or SPASM program at the TIRR Memorial Hermann, Dr. Ivanhoe is a leading figure in PM&R, specializing in brain injury and spasticity management. With distinctions such as the Distinguished Clinical Award from the AAPM&R, her work is widely recognized, having been named among America's best doctors for over a decade. Dr. Ivanhoe's passion for advancing treatment and technology reflects her commitment to improving patient outcomes, and she brings a compassionate and culturally sensitive approach to her work, always incorporating patient preferences into her care plans. We are thrilled to explore her insights, discuss her journey, and gather her advice for emerging professionals in the field like myself. So Dr. Ivanhoe, we are so happy to have you here. Can you share a bit about your journey into the field of physical medicine and rehab, and what motivated you to specialize in brain injury as well as spasticity management?
You may have to repeat that question. It was loaded.
Yeah.
So why don't we start with how I got motivated to do brain injury and PM&R? I think I always knew about the field, even though it's a relatively small field, because I knew a pediatric physiatrist who was probably, I don't know, 20 years older than I was. Our mothers were friends. And so I knew about the field. I did a summer while I was in college at the Rusk Institute in Pediatrics. And when I finally told my parents I was going to go into this field, they were surprised because they said, "We've never seen you as depressed as you were that summer." But growing up, I had friends who had siblings with different disabilities. The more I think about it, the more I realize I knew people with different disabilities. I was always very patient. Not so much with myself, but with other people. And there have just been times in my life where I think I've always just recognized that even though those people may be different or outliers in a way, they are still human beings and they still deserve to be treated appropriately. Why I picked the field of brain injury, never expecting to have a pretty well-developed career path, but I did my residency in a little-known residency program. Not people kind of think that because of things I've achieved that I must have gone to one of the more well-renowned programs. I did not, and I ended up chief resident. And I wanted to do a fellowship because I felt like I'd just be like the local PM&R doc, and I wanted more exposure to brain injuries of different types. I also was interested in spasticity back then, because when you have an interest in brain injury, you realize how limiting the typical, which haven't changed in years, typical treatments, the typical oral meds that you use in spasticity. We'll have another conversation someday about what spasticity is, how limiting they are in terms of patients' lives, outcomes, potential, even more. So my career didn't quite go that way. I did a fellowship at Baylor College of Medicine, which was largely at TIRR, which wasn't even TIRR Memorial Hermann yet, but it became that later. I ended up the director of brain injury and stroke at TIRR for a number of years. And during that time, I had wanted TIRR to create like post-acute programming or a residential rehab program outside of the confines of a hospital. And there was very limited interest. So when there was an opportunity for me to do that, I did that on my own, on the side, but I always have had a foot at TIRR my entire career, one way or the other, variable degrees. Mm-hmm. So I created a program with some other people that grew, became also very well-established post-acute residential brain injury program. Meaning you get out of a place like TIRR, especially now with the insurance pressures and length of stay pressures, and people still have a lot of goals. They may or may not be able to access those opportunities. And we'll probably end up talking a little bit about why they may or may not. But that program grew to 4 different programs and 3 levels of care. And then private equity acquired us, and that was the end of my involvement and many other clinicians' involvement with that particular program.
Mhm.
And it still exists under a different name, but it's a very different approach to programming for its patients.
Mhm.
So in terms of SPASM itself, when I was a resident, I went to a lecture about intrathecal baclofen pumps, which were barely FDA approved at that time. And I wanted to do studies or look at the effects of intrathecal baclofen on people with brain injuries, because as I said, even back then we knew that oral meds were useless, essentially useless, but they have a very small role. And then so I started, at that time, Medtronic was not interested in doing it, so I started doing it on my own anyway. I went through all the hoops that you have to jump through, and then a few years later, they were interested, not because of me, but they were interested. And so I was working with another physiatrist, Stuart Yablon. We used to call each other our colleagues in crime. And we had a deal. You go learn how to inject botulinum toxin. I learned how to manage baclofen pumps, and then we cross-trained. Eventually, Stuart moved on. We're still friends. And little by little, I've had experience with all the different toxins that are available to inject. I'll often say, if you're an injector, you're an injector. Like, people will break up, oh, I only do cervical dystonia, I only do migraine. I don't really break it up that way at all. If I can get to it with my needle, I would probably consider injecting it. But eventually, aside from that, I've ended up I'm happy to say, because I know I tried to get you to join this, the International Neurotoxin Association. I'm on the educational committee for the next meeting in Madrid. And for those of you, particularly medical students and residents who may be listening, membership is very affordable. It is free. So great meeting, but I'm a part of the board for INA, as well as the educational committee for the next meeting. And so those are some of the paths that have kind of led me where I am. I feel like I'm babbling. Did I answer your questions?
Yes, you very much so did. Yeah, because you're very passionate about spasticity and brain injury management with the short period of time that I've gotten to know you. So that was pretty much, I wanted to know how you got to that point, which you did an amazing job of sharing.
Thank you. That's a lot of work.
Yeah, definitely sounds like it. And you also briefly touched on some of the managements and treatments with injections, baclofen pump. But throughout the course of your experience, how would you say the treatment approach, especially for spasticity, has evolved over the years?
I probably have a bias because of where I work and how aggressively I often tend to treat patients, that it hasn't evolved enough at all. And that's my opinion, and probably bias. And I'll tell you, I'm part of the STEP certification process. The American Academy of Physical Medicine and Rehab has a program to get a certification in spasticity, basically. And it's wonderful to see the physicians and sometimes med students who sign up to be a part of that process. And I realize how variable the educational experience is in treating that, in injecting, in understanding baclofen pumps, in understanding it's not just I put your pump in and I'm done. I went into PM&R partly because I like having long-term relationships with my patients. You saw it in clinic, they'll come in, they'll be like, oh, how's your grandchild? And, or just, I know them mostly. And sometimes knowing their social situation is very often, I think, a part of being a good physiatrist. For a lot of reasons, and we'll probably talk a little bit about social determinants of health, but, how has it evolved? So it's very variable. And I guess that's why I say it hasn't evolved. I don't think it should be, like medications for heart failure. If you're a cardiologist, most of them know how to treat that. But spasticity, patients are told all kinds of mixed things, even within my field. And so much depends on who treats you and what the expectations are. And, if you set a low bar for your patients, that's all they're going to get. And if you set a higher bar, they will often surprise us. So it's changed in that there's baclofen pump accessibility in some places, but that pump's been approved since 1992 and 1996 for spinal and cerebral origin spasticity. And you tell people it's been around that long, and they're like, "Oh, really? I thought it was still experimental." No, not experimental. And there are probably a lot of reasons for that. But it's a shame. So your patient shows up in an emergency room, has a baclofen pump. I once did a course one year for an academy meeting. I called it "Everything that goes wrong in my day must be from that baclofen pump," because a patient shows up and they have a pump, they could be in an emergency room for anything, but the pump will be the get the blame, right? In terms of botulinum toxins, when I first started as an injector, there was only one botulinum toxin you can inject. You can guess what it was. Can you guess what it was? Botox.
Botox, yeah.
Verb. I'm going to Botox you, even if what I'm injecting isn't Botox, people will say that, right? And now there are several botulinum toxins available, several companies involved, studies on shorter term and longer term lasting botulinum toxins. There's so much we still don't know that I would have thought by this point in my career we'd know more. And the other thing is physician, therapist, family biases. You can't ignore those, you know. And so even I don't want to take away people's hope, because you do that and there are all kinds of side effects from taking away their hope. I also tend to try to be realistic or break it up into baby steps of, let's do this first. But overall, how has it changed? There are more options available. There are more toxins available. There are increasing devices that will probably have some benefit for spasticity and for movement disorders. And in general, the definition of spasticity is changing. And until my generation and even a generation behind me dies out in medicine, they'll probably still use the current definition that you guys learned for your boards. So in some places it's changed, in some places it hasn't. That's a really long answer to that summary. But there are a lot of people out there who have an interest in it, and don't know how to access or set up a spasticity, program or office, or I've done it in inpatient, outpatient. I've done it long-term for people. It's, brain injury is increasingly recognized as a chronic illness. It's not like you got your injury and you're done. It's sort of like cerebral palsy. Some people thought that at 18 or 21, you're done with it. No, because things keep evolving. We all keep evolving. And some of what I think I like to do as a physiatrist, and hopefully instilled in you and other students, is paying attention and trying to follow patients along whatever that path is as best as we can.
Oh, I love the fact that you highlighted that, because more times than not, in our medical education, in our boards, we're taught this is the disease, this is the treatment, and we get questions on it, that what is the best next step? And what you highlighted there is to never ever forget the individualized approach to care that every patient needs, whether that's in PM&R or in other fields, but more so in PM&R, because not every, for instance, brain injury patient is like the next one that we see. And I wondered if, in your experience, even environmental factors, that's been a thing that you've come across, and you've even been like, wow, okay, this patient, like, they've had similar-ish injuries, but because of this environment versus this environment, they've had very different responses to treatment, or their disease progression, or not disease, or their disability progression has been very different because of the environment.
So, excuse me, tell me what you're thinking of when you say environment.
I guess I'm still kind of thinking about that socioeconomic background, like the psychosocial model of care, right? Because let's say someone who has a disability, a lot of times they might be on government aid, not have the best access to care, to like clinics, for instance. Let's say they have to take a 30-minute ride to get to the nearest spasticity or to get to their appointment versus someone who has their caregivers more affluent. They've had their car better equipped to their equipments, and they don't have to go through, I guess, those challenges of, for instance, getting to their appointment. So that's some of the environmental factors I was thinking.
Yeah, I am very often so impressed by my patients and their families who don't have means, basically, and what they will pull off, whether it's getting to an appointment. You've been in my clinic, it's hard for me to run on time, not just because I can talk too much, but because if a patient just spent 3 hours on public transportation trying to come and see me and they show up late, I'm not going to say, I'm sorry, come back in 3 months. It doesn't work that way. I wouldn't want that. So, it's a huge issue. It's a really huge issue. You're my third Zoom call today, and this has come up, and they're all about different issues. One's about the Real Abilities Arts Festival. I just plugged Real Abilities, February in Houston. And one was about another project a friend of mine's working on, and you can't talk about disability, I don't think, without acknowledging that elephant in the room. We can come up with all kinds of wonderful treatments or ways to study something, but if the money's not there, it doesn't happen. And maybe I'm just I am getting older, and I don't like to think I'm jaded, but it feels like it's harder and harder to get people what they've needed. So everything, I grew up in a system in PM&R where it was about looking at the whole patient. And some programs still look at it that way and some programs don't. Some physiatrists look at it that way and some physiatrists won't. And it's a question of, I think, who we are personally. It's probably partly our own personal experiences. And that includes where we train, how we train, the patients we meet, and if we subspecialize or not. But I went into PM&R to be essentially sometimes that case manager, social worker, because it's part of who my patient is. So we can talk about educational levels matter, which patients understand more or less why we do the things we do. And it can take a lot of time to try and make those points. And it had that much time, but you say it over and over again, sooner or later, if it's necessary, you reinforce it. A patient may or may not have access to or a way to get to the care, whether they understand or not why it's important. And depending on the severity of their disability, it takes a lot. One of the movies that we've shown in Real Abilities, you saw it, was called, what was it called? Oh no, Imperfect. And it starts with the director of a movie, not of a movie, but of a play that's going to be put together by a bunch of people with assorted disabilities, and she's a paraplegic or has paraplegia, and how much it takes for her to get out of bed, to move her legs, to go and shower, and those are also factors. Do you have help? Do you want help? You might not want help. There are so many considerations. Bladder and bowel management can be influenced by what access you have, what meds your insurance will or won't let you get, and if you can afford to buy the one that works, that may or may not be covered. So there are tons of moving parts. I know I don't always get it right. Maybe I never get it right. But all those things really matter. Is your patient's diet going to affect their bladder and bowel management? Do they have the equipment they need? Or if you go to an inpatient rehab program, you're an inpatient and you practice transfers maybe to the right, but then you get home and you've got to transfer to the left. I mean, all those factors, if the goal is to make someone's life better and hopefully give them access to propel their ongoing future in a better direction, then you really have to be somewhat cognizant of all those other parts. To answer that question.
Yes, very beautifully. Cultural competency, y'all. That's what I hear over and over. And also for those that might be, medical students just exploring the field of PM&R, patient advocacy is one of the biggest parts of the field that I saw, like from my first rotation with you guys. And I think it's beautiful, but at the same time, it can get tiring. And I've seen it negatively influence some of the physicians, right? And that can be one of the leading cause of burnouts, especially in PM&R, because it can feel like you're banging your head against the wall. But unfortunately, that's just part of it. But I think there is hope for change because I'm a big believer that you should be the change you wish to see in the world. So hopefully the next generation, I don't know, I'm hopeful. I'm hopeful that we can.
Good. You're young. No, that's good though. No, you need people to be hopeful. Go on. You're hopeful to
Right.
what?
Right. I'm hopeful that, and I'll be very honest, like I don't know much as in depth about the insurance, the details, the prior auth, and how all those things work. Just because I feel like I'm at that stage of medical education that I still need to get the basics down right, but hopefully I will learn those things in residency when I deal with it. But I do hope that there influences that we can have that I don't know, as physicians, we can be the voice for our patients and we can continue to advocate so that they can get the help that they deserve. Because like you said, sometimes it can take patients 3 hours to get to the clinic, and there are definitely clinics and physicians who choose not to see the patient because they missed their appointment. So at least one of the changes can be that, hey, be lenient with your patients with disability because it did take them a long time to get to the clinic, and at least we can be helping them rather than making their life harder.
Yeah. I had a patient this week where I got a text from the nurse saying your 9:30 patient is 30 minutes late. Do you want me to tell them to go away? And first I texted him like, well, who is it? And then before she could answer me, I said, yes, of course, I'll see them. I didn't know who it was. And it turned out it was a patient who came from a good 60, 70 miles away, who I've known for a long time. I know that her mother had just had a stroke and had spine surgery. I know what the issues are. I'm not going to say no, drive back home and get in when you can get in. No, I mean, that's just inhumane to me. And I have enough trouble myself getting into my own doctor's appointments sometimes or getting them scheduled. So, but it takes a lot of patience. It takes a lot of empathy, I think. And you said advocacy. One of the biggest issues, I think, in my field and the burnout is the paperwork, oversight. And I worry about what we're training you guys coming up behind us, close that encounter in Epic, or did you bill correctly, or what codes did you put down, as opposed to how do you think that patient felt when you took away all their hope when you were talking to them? Or sometimes I've been known to say to some residents or fellows, when you're going off making yourself sound like an impressive physician, read the room. Did they tune you out because you overwhelmed them? Did you overwhelm them with vocabulary? Did you overwhelm them because of their emotional situation? Read the room, look away from the computer. And I know that's like somebody will say, oh, that's just generational, Cindy. No, we're still human and we sometimes lose that. I mean, and in terms of culture, we need to factor in our own culture wherever we work, of what's important, of how people engage with each other. Aside from the cultures of, who's from a Hispanic background, who's from a Vietnamese background, who's from, whatever. And, it's a factor. It's a factor sometimes. Culturally aside, it can be a factor in terms of how much a family actually allows their loved one to progress, because we all want to do what's right for our family members and we want to protect them. But I grew up with a mother who said, my job is to have you be able to function on your own without me. And sometimes I think about that when I when I engage with some of my patients and their families. And, at what point do we stop that? At what point do we enable, and at what point are we giving you the freedom? Sometimes it's okay if you fall on the floor.
Yeah.
As long as you don't hurt your head again or your neck, it's okay.
Yeah. For those that are not watching this, if you guys could see me, I was just looking like a bobblehead going back and forth. I 100% agree. I do want to touch on one of the points that you brought up about empathy and not trying to sound smart, right? Because if you think about it, a lot of times, especially the patient population with PM&R was a very niche patient population. Think about it. They've had, like, let's say someone who's been fully able, they've had an injury, and now they're learning to live with their new disability, right? And someone who's been stripped away from so much at the doctor's appointment, where could be honestly one out of the so many days that someone has asked them, how do you feel, rather than, or just the attention's been given to them. So I think providing that space is a lot more important, because if you think about it, they need help at their most vulnerable stages for bowel, bladder. A lot of times, some patients cannot fully carry on with their bowel and bladder program, so they need a caregiver. And if you think about it, that's a very vulnerable task to have someone else do for you.
Invasive.
What's that?
Yeah, it's invasive.
Right, exactly. It's very invasive. And at a doctor's room where we can empower our patients, where we can allow them to express how they feel, we can work on a medication management, whatever that is, with them as part of the team. And then we try and either show off, or we just get so caught up in charting and whatever that is, that we take away that one moment that they've had to feel that, hey, I'm in control of my life. So I think once you put that, I was like, whoa, that is especially in PM&R is way more important, in my opinion. Because I mean, in all the fields are important, but in PM&R, especially with what a lot of patients go through, just because of because of that. So
yeah, I mean, sometimes, people, I saw this a little bit more in inpatient, but I can see it in other settings too, where they'll start to become between whoever the medical professional is, the physician, the therapist, the nurses, whatever, versus the patient or patient and family. There becomes like it's tug of war, like a power struggle. And you have to take a step out. Same thing with parenting. You have to take a step out and go, is this my issue or is this their issue? Right. And do I have to win this battle as a healthcare professional, or, is it going to be dangerous if I let them try it that way? Or do they just need a little bit of control? We all want that. We all want that autonomy. You learn about that in medical school. I'm sure you still do. And then sometimes we forget to give it to them. And so you kind of pick your battles. And is it worth it? And if they think that bowel program is going to work better than this one, or they think that splinting that wrist is useless, well, maybe it's useless because they just told you they're not going to do it. Right?
yes, listen.
So, and it shouldn't be this conflict. It should be, how do we get there together?
Right.
So there was a time in my own life, well, nobody's going to not be touched by disability, whether it happens to one of us or short-term, long-term, happens to a family member. I know I've gone through it with different people in my family. And, you kind of have to remember that, I think, and hold on to what those feelings are like. And I remember one time when one of my family members was ill, and we got to, like, I don't know, fifth physician in the mix of people trying to treat and not speaking to each other. Fortunately, I was in the mix, so I could do that. But and this one doctor asked the patient, I'm trying to be subtle here, okay, you have this symptom and this symptom, and this is an issue, and you have this issue. Where do you want to start? What do you want me to help you address first? And that left a mark on me in terms of how I approach my own patients at times, because a patient can come in and give you a laundry list, or we may assume we know what they're experiencing based on what their injuries are or their disabilities are. That doesn't mean that's what's important to them. And it's the same thing treating spasticity. I'll get patients sometimes where they've been treated a certain way, and I'll say, well, what do you want to have happen? And that's not what they were looking for. They were looking to clean their hand. So it's important to be in that conversation, I think.
My first rotation of my third year was psychiatry. And even though it was outpatient, I learned so much. Not as much psychiatry, but a lot of life lessons and a lot about patient care. And one of the biggest things I learned from him was to start every appointment, or that's how he would start, especially the new patients, with what are the 3 goals for your visit today? And that not only would allow him to better focus and provide better care for the patient, but also would allow the patient to like take a second and be like, out of everything that's going on, what is important to me? So I agree. It makes it to be a lot more efficient, and hopefully, less burnout, less burnout for the physician as well, who's getting overwhelmed. Like, okay, there's so much going on. What do I do? And then here, let's tackle this rather than allowing the patient to be a part of the decision making.
A colleague of mine had commented the other day that he was I'm not going to say where this person works, disgusted. And I said, really? He goes, it's not the patients at all. It's the micromanagement and the requirements. And, you'll have institution requirements, you'll have board requirements, you have paperwork requirements, you have a lot of stuff that contributes to that burnout. And somebody asked me at one point, how do you keep from burning out? And I said, who said I kept from burning out? And but my answer was, I try, and I don't always pull this one off, but I try to stay focused on that person in front of me at this moment is what matters most. And what if I was that person or that mother or that, grandmother or whatever, then they don't care that I have to go and justify ridiculous things and do requests for prior authorization for medication for the 3rd time on the same prescription. They don't care about that. I think that, maybe as some of the things in healthcare that have changed during the course of my career, the documentation, electronic prescriptions, the abilities to get records from other places, that's not easier. Trust me, it'll hopefully get there. But hopefully as some of that streamlines, maybe some of the other redundancy, that's a better word than the one that went through my head. Redundancy will also streamline a bit. But some of it's ridiculous. A lot of it is.
Right. Yes. This conjunction.
You'll see.
Oh, I feel like I've seen it actually in my family medicine rotation. So I was back in Utah still. And just from the main hospital to, and it was actually, I just remembered it was one of the very first PM&R patient cases that I saw. And I was like, whoa, this is very different than a typical family medicine case that I see, but it was a post-hospital stay follow-up. And it was so hard for us to get his records from the hospital just to his primary care. And that it's still a thing. It's still a thing where the medical EMRs don't communicate to each other. And it does affect not only the patient, but also, again, the physician, and like we said, burnout once again. So hopefully with new technology and AI, that can be figured out. I'm hopeful. I don't know.
I'll tell you one of the things that's a little scary, and maybe, maybe by telling this little caveat, it will make sure that your generation of physicians doesn't screw this up. Okay. So, my son had applied for a special kind of insurance as I try to figure out how to leave him everything. And they wouldn't approve him. And short version, I know I'm trying to shorten some of my responses. Short version is going back and forth over the course of several months, we found out that one of his diagnoses had been miscoded. And because things got miscoded in an electronic health record, you couldn't get rid of it. And it was wrong. It was really wrong. And it took letters and letters to the insurance company, and it's still going to be in his healthcare record. You can't get it out. He never had a bleed in his head. Okay. Never. I would have noticed. It's what I do for a living, right? But I mean, my point being, a lot gets carried over that shouldn't. Another thing that I've seen happen a lot in electronic health records is people can be on things like Seroquel for sleep. And I had a patient who had no psychiatric history. This is one. This happens a lot though. One, and had taken Seroquel for sleep only, and it got coded by whomever was doing the coding, that she was like bipolar, or bipolar, because it got it covered. She's not bipolar. Or I've had patients where some women still take SSRIs, serotonergic selective serotonergic reuptake inhibitors, for premenstrual dysphoria. They get admitted with a diagnosis of depression. It's not depression, right? But things get attached appropriately or inappropriately in an electronic health record. And it can be really difficult to explain that away, because you have to go through spinning beach balls or spinning circles as things load. And it takes a long time to go. Nobody's going to go through all those records, no matter how accessible they've now become. So it's really just cautionary. It's all in there somewhere. Maybe as years go by, it'll get easier to search for things or get easier to undo things. But, good and bad, the ugly.
Yeah, I think it would be very beneficial if one of the annual visits, or I guess most insurances cover at least one annual visit, right? In that annual visit, just have an extra 5 minutes where the MA or the nurse can just check with the patients, hey, this is what we have on file. Is this everything that you agree with, or do we need to modify something? So kind of, I'm thinking of that Swiss cheese model to just have at least one little stop in the big system. So hopefully at least that diagnosis isn't attached mistakenly to the patient. Because that can also have a negative connotation when the patient's like you said, for your son, never had brain bleed, but somebody and that was on board. So
but is the biases that we attach to things. And I've joked that I have a bias against people with biases, because I'm sure I have other biases I don't necessarily notice. But I think should be cautionary about how we assume things. I have a patient I've followed since in the middle of COVID. I sort of inherited her, and she had a horrible degloving injury of a leg. She is massively tattooed, and it was a motorcycle crash, and she had a severe TBI. And before her, let's just say her behaviors are make it very difficult. But her husband's salt of the earth, takes great care of her, no matter how many times she may hit him. We've never gotten to good meds, me or the psychiatrist, with taking care of her. But point being, everyone's assumed that she was like that before her injury. No, she was like a good church going, working full-time mom. But because it was a motorcycle crash and because she's tattooed, people jump to conclusions about who she was even before her injury. I often tell patients or families more, before their loved one gets admitted to an inpatient facility. It could be inpatient rehab, it could be going to a skilled facility, it could be going to a nursing home. Put up pictures of who you see in your head. Put up pictures of who that person was before this happened to them, because it helps healthcare providers have a better sense of who they were and what it is you see. We'll tell patients, oh, or the families, they're recovering really well. And to them, that means they're going to be back to who they were before. To us, it means they completed a sentence in speech therapy or the transfer was better, right? So I think it's important in this field, especially, probably in all fields, but when dealing with disability, for people to have that context.
Right, right. Especially that it's such a new thing for the family, right, to navigate. So the appropriate lingo, it's a very different world, even for medical students, right? Learning about PM&R. It's not like other things that we've seen. Even the approach of PM&R to care, it focuses on function. And I think a lot of the other fields, it's more so medication, disease versus we don't really do that in PM&R. So I can definitely see that be a challenge for families to navigate. So we talked a lot about patient advocacy, and we touched on brain injury here and there, and talking about real abilities. I remember one of the movies that you showed us, it was called Brain Damaged by Paul Nadler, if I said that right. Yeah, which I very much so recommend everyone to watch because it really gave me an insight into someone's head with TBI and their experience, right? Because like you said, a lot of us, whether you want it or not, we do have our own biases based on the environment that we were raised, but based on the culture that we come with, we have our biases. And that's okay. That's okay, in my opinion. I think it's just the important thing is being aware of your own biases and checking yourself when you have biases. And that comes with self-awareness. But yeah, so back to the little documentary that we saw. So one of the things that was highlighted in Brain Damage was his emphasis on the fact that the doctor isn't talking to me. Why aren't you talking to me? So how would you say, as a physician, you can incorporate your patient preferences into developing a treatment plan for the patient? Because at the same time, I think, or I wonder, are there certain criteria that you would need to go through? And if there are, how you can incorporate like patients' preferences and understand or help them to get to more of that independence level. I don't know if I'm making sense with that.
How do you make the patient feel more a part of?
Yeah, of decision making, and not just, hey, let's hear them out, but a more applicable, I guess, response that our listeners can incorporate into their practice, whether they're medical, aspiring physiatrists or residents.
I think it's important, and I'm sure I'm guilty of not always doing this. I just have to own that, because sometimes when there's only one person in the room who's talking, you tend to talk to that person, and it might not be your patient. But try to face them all is one big thing, and make eye contact back and forth. And try to understand where they came from. We're talking more the acute patient, especially, I think, right? Give patients choices, let them have a voice in the plan of care. If they can tell you or indicate to you, try to find out who they were before. Like a patient I saw that the other day, it's always easier for me when I can draw on a very recent experience. It's too bad I haven't kept a catalog for 30 years, but where had ADHD. There's an increased incidence of traumatic brain injuries in people who have ADHD to begin with. And I asked him what medications he'd been on before that were helpful, which ones he had trialed before. Because it's still that same brain. It might be working a little bit differently, but it's kind of, it was just a way to draw him out. And he did what a lot of patients will do, where he just looked at his family member, and his family member didn't answer for him, which was great. And I said, I'm sorry, I asked you. You just told me you want to grow up and move out of the house. You're going to turn to your family member? So trying to include people. Give them the option of, does your bowel program work or not? I mean, I'm sort of fixated on bowels today for some reason, but why don't you wear that splint? If I do these injections, it's going to be every 3 months. Here's what I'm hoping will happen, but I can't tell you what will or won't. What do you think of that? It's sort of like, your kids get in the car at the end of the school day, they would tell you, don't say how was school, because you're gonna get a one-word answer. Fine. ask a little bit deeper questions like you do now, So I think that's important, just being aware of the fact that patients have lost that autonomy, and sometimes giving them choices, if they're able, sometimes they're not able. But at least at maybe having to try to have them understand why you do things, why the things we do. Why are we doing what we're doing for them, or why we think we want to help them? And again, read that room, don't give them long discussions about neurotransmitters and whatever. Half the time medical students don't want to listen to that. But, small pieces of useful information. Same for the families. They are in so much overwhelm, especially as lengths of stay are shrinking and outside pressures of funding and discharge planning and where are we going from here and what's the future going to bring are just crammed into a really small amount of time for them. And, we'll often say different venues where I either have been involved with the model systems or the program I ran or other things. If you've seen one patient with a brain injury, you probably heard this, you've seen one patient with a brain injury. Every brain was different before. Everyone's psychosocial makeup and situations are different. And maybe that's one of the reasons I like brain injury. It's you have to be a little bit creative.
I agree. You did a great job of highlighting what can be often neglected, and that's caregiver burden as well. You mentioned family, but I interpreted it as caregiver, right? Or caregiver burden. Yeah, a lot of times these patients need help to navigate their day-to-day activities. And making sure everyone is on the same page is really important. And I've seen it where, for instance, there are family meetings where PTs have family members come in so they can get a bit more acquainted on how new transfers look like for the patient, how using the restroom for the patient looks like now. And those are important things for the families to be a part of, so they can help with their loved one and the care that they get. And you also touched on some of the barriers that patients with brain injury experience. One of the ways that I know you're a big advocate for it is through your support with the real abilities and, sharing their message. But what other ways would you say, as medical students and residents, can we improve advocacy efforts for patients with brain injuries?
So I kind of look at it, right or wrong, as there's bottom up and top down. I sound very corporate. And the bottom up is helping families or patients or caregivers actually know what the obstacles are that we as physicians are facing to get them care, right? And they can be like just local, how many doctors does your admin support questions, and did that email come through yet? Or, and it could be doing the paperwork, which is draining all of us at this point, and fighting the fight and doing that peer-to-peer. It's very rare that I decline to do a peer-to-peer. And peer-to-peer, for people who might not know, is when I may prescribe something or recommend a treatment, and then the insurance, and this is true with Medicare replacements and secondary insurances, all these things that students probably don't really quite grasp yet. And I'm sorry, because you will, but doing the peer-to-peer to justify the treatment I have suggested or done paperwork to get in the first place, right? And there was a time where I could always get a peer-to-peer overturned and approved. And then it's gotten harder and harder and harder. And this could be a toxin treatment, a medication treatment, rarely, but it has happened in the last year and a half, intrathecal baclofen pump implant, which was ridiculous. Doing those, I think, is important. And you try to take that as an opportunity to educate the person on the other side of the phone, right? I find that after all these years of doing it and trying to explain things, there was one time I got really angry. I did. I got a little hostile. But it was already clear that she was just not going to hear me, and she wasn't going to, the physician on the other end of the phone. She had decided that my patient did not deserve another inpatient rehab experience. And I had asked for 2 whole weeks, which is nothing. I had defined really good, reasonable, can be accomplished goals. And the answer was send him to a skilled facility. And it was so ridiculous, for a host of different reasons. But for the most part, it's an opportunity to educate them. And, one of the few good things of growing old in the field is that I can say, I have done this for this amount of years. When we first started injecting botulinum toxins before the FDA approval, here's how much we could give, and insurance covered it. So really, please don't tell me that you're worried about my patient's safety, because I will tell you this is not going to kill them, but the meds you want them on are more likely to be offensive. But that, I think that's one like bottom up level of advocacy, and also letting patients know, if we know, the different things that they can do to fight for something if they have the energy. It's very time consuming. And sometimes, because the funding source can get in the way of delivering care, they undo what you can do for that patient, right? If I inject someone and I want them to start therapy, but I'm fighting with whatever coverage they have for the next 3 months, by the time they get to therapy, the toxins have worn off. You see what I mean? Or they have a complication from their spasticity. You guys are all going to be taught that if somebody's spasticity gets worse, look for something that's causing it, right? Look for typical things that medical students and residents get told: a tight leg bag, a kinked catheter, a pressure sore. Those things can make your spasticity worse. True. I have a talk that I don't know that I've ever actually given it as a full talk, but it is, what does your spasticity make worse in the first place? Right? It's sort of looking at it from the other perspective. If you have restriction of your lungs because you can't take a deep breath, you're going to have trouble with expanding those lungs. If you can't transfer and you're getting contractures because your spasticity is not being treated, your fall risk, your skin breakdown risk, your pain, your joints, all those things are at greater risk as well. So, it's sort of a circular way to look at how all these things interact. And it's very easy, I think, you talk about critical thinking, but we do compartmentalize a lot in the way we teach people, and life isn't necessarily going to go that way. So, in terms of advocacy, otherwise, there are organizations that in the field that you may or may not align with. There's ACRM, American Congress of Rehab Medicine. There's AAPMR, American Academy of Physical Medicine and Rehab. There are brain injury associations. Locally, I have testified one time for Medicaid to cover baclofen pump refills. That's state. Things along those lines. There are more than enough opportunities. I think sometimes the problem is they don't all communicate with each other, right? Kind of like an electronic health record.
Yeah, it's all the same thing. Well, not really, but
It's our culture.
yes, it's horticulture. I like that bottom-up approach to help families with better understanding the obstacles, just because I felt that during my audition rotation, I didn't know a lot of the struggles that the patient were going through. And as someone who's quote unquote already in the system, I myself struggle to understand, let alone the families.
Right.
So that becomes so much more important to make sure that we are doing that education piece. Just because if we're lost, then the patient's families are just as lost.
And they're getting all that mail. right? They're getting bills that are pink because they haven't had time to open them. This is a lot more in the acute stage, but longer term, there are a lot of demands on them as well. And they could be on the demands on the patient as well. You might be struggling even more to get through all the day-to-day living stuff.
Right.
So, which reminds me, there's something I didn't take care of that I have to take care of today. Yeah, thanks, Megan.
Yeah.
Yeah, but
Are there state funds or organizations that do help financially with patients who are going through those challenging times?
it depends on the degree of disability. It'll depend on your state.
Mm.
Texas has Texas Workforce. They have CRS funds, Comprehensive Rehabilitation Services. Those are some sources. There are waiting lists for that. Sometimes there's crime victims. But a patient of mine recently lost her crime victims assistance. Nobody knows why. So her mother, who had the stroke and the spine surgery that I was talking about, because she's fresh in my head, she's trying to work through all that, plus her own medical care and her daughter's care, right? Her daughter had been beaten years ago. And it's really hard. It's really hard and it's exhausting. And sometimes they get to an equilibrium with their lives, right? Where it's like, I understand you mean well, Dr. Ivanhoe, but I can't do it anymore. Okay, that's fine. I was often, not always, I never, always, never. I'll tell them, look, you have to tell me, this is what I see as potential. Here's what it would take. You have to tell me if that's worth it to you. It might not be. Same thing with the toxins, they generally last, depending on certain situations, on average 3 months. Do they really last 3 months? Some do, some don't, but that's all we can get covered. So that's how we inject it. And there are some other more scientific reasons that may or may not actually be true for why we do them only every 3 months. But it's an investment, not just financially. There was a time, even though I've always been at TIRR in some form or fashion, part-time, full-time, where I had a private practice. And if a patient came in, they knew ahead of time how much their share of paying for their health care for this intervention on that day was going to be. I had a great office manager. She worked that out with them. And they would have to tell me, I can only afford X. So what can we do if I can afford X? And we would work through, is it worth it for you at all? Here's what I think I can do with that. Here's what I think if we do more. It's a shame it had to be that way. It still has to be that way, because now patients will sometimes get bills afterward. I get bills when I go to the physician sometimes. I'm like, I thought I paid that. Oh, you paid your copay, but this is part of, it's crazy. It's crazy.
Yes.
It doesn't need to be that complicated, but it is. That's our system.
Yeah.
So go fix that.
I'll see what I can do. I'll see what I can do.
Yeah, okay, thank you.
Gotta learn the medicine part first, and then, or
Or
actually,
do it all together. Huh?
yeah. I said both of them at the same time.
Yeah, because the tail wags the dog.
Right. So we talked a bit about, or we've been talking about advocacy, how to help your patient be part of the process, part of the decision making. And I really appreciate that you have that model in your previous private practice, because as much as I wish it wasn't, money does make a lot of influence on patients' care. And that is a very individualized approach to, hey, what can you cover and what you can't. Now let's gear or shift some of the gear toward research. And are there areas that you think in specifically patient advocacy that has been not looked at as much or underfunded in the field of rehab? So this is more general. It doesn't have to be spasticity, it doesn't have to be brain injury, anything else there.
Yeah, yes. And I'm not a giant researcher. I've done some here and there. I'm involved with some a little bit more peripherally. Recently, there's a project that I obviously have a big interest in how we provide care and what happens when we don't. And sometimes I'm surprised by the research that we need to have research to prove. Like, does it make sense that if you have access to care, you'll have a better outcome than if you don't have access to care? It makes sense to me, but we need to prove that. So hopefully I'm going to be part of a study now that actually does compare who doesn't get services with who does, or how lengths of stay are impacted, because lengths of stay are no longer determined by medical necessity. They're determined by contracts with insurance.
Yeah.
And they don't factor in, okay, well, I went from here, I was an inpatient, but then I went to this post-acute program, but I could only stay there this long because of the funder, not because I didn't reach goals or because I got sick and transferred back to a hospital. So I think that is huge. We like to compartmentalize things and we look for what are our primary outcomes, but we don't necessarily entirely put a lot of credence in how important those other outcomes are. So in terms of looking at the greater, bigger picture, quality of life, our humanism as people, where that person is later, did that TBI patient end up in prison or on the streets because they couldn't get services that would get them either on good meds or off bad meds, or give them vocational services, or, sometimes with some of my patients, that's what I'm looking for, is to keep them off the streets, because then they're going to get another TBI often. It happens. One TBI predisposes potentially drug or alcohol use can predispose you to another injury. So I don't think we do a good enough job in terms of advocacy at demonstrating how it's a tumbling effect. It's a domino effect, right? In terms of research, I think that I'm not anti-research, so I hope that won't give you the impression, but I am pro using that research with the art of medicine in terms of what it means for a particular person, and really reading it, because it's very easy, and I'm guilty of it at times myself, just read the conclusions, because there's a lot out there. But really looking more in depth at, well, who were the patients and what were the measures? And were those measures going to capture something that would still be significant, or was it going to miss something that might still be significant? Was there a bias built into the way it was studied, right? So really looking at it, I'll hear medical students, I'll hear colleagues say to me, oh, that's not FDA approved. So far, things don't necessarily need to be FDA approved for the way we use them. If you end up here, I will have a project for you on what medications are FDA approved and how we use them and why. Because people don't realize that studies get designed to answer the FDA specific questions. It doesn't mean that's necessarily going to be the only way that medication's used. So in terms of research, a lot's changed over the course of my career. I can't go by stuff I learned as a resident necessarily. I need to look into that more deeply. I was reading an article, you go down these rabbit holes, you look up something online, and you can click here, and then you can click there, and then you find what was the original study I was looking for. But how we treat heterotopic ossification after a traumatic brain injury has always been based on hip replacements. And now there was a meta-analysis that went back and looked at spinal cord and brain injury and how we treat HO. I'm not going to give it away. You'll have to look for it. But a lot of what we think we've been doing is probably not helpful and probably doesn't matter one way or the other. And yet I found in reading that article that outside of my university or Texas Medical Center, largest medical center in the world, even the orthopedists I deal with are still out of touch. I hope I didn't name them. Based off of at least that article. So there are a lot of questions in terms of how people are getting treated and what services they access and who they access that from. I'll tell patients, you don't want to go for that tendon transfer to the patient, to the physician who says, I did that when I was a resident 20 years ago. You have a certain degree of comfort level, and how things get done isn't just based on articles, it's also based on the expertise of the person delivering the care. So I'm a bit rambling, but in terms of research, there's a lot out there, and you can find research to support your biases, either way. So, there are not enough hours in the day for us to read everything and necessarily perform or form an opinion. But I think just being open to the fact that there are holes is important. And then you have to factor those holes in with who you're treating.
Right. Medicine is an ever evolving field, and it's important to stay up to date. I feel like once you enter medicine, you really need to internalize the identity of a lifelong learner to be a successful physician. So it definitely makes sense with what you said. Question about what you mentioned with the length of stay at the hospital and how it's now determined by insurance. I did see that as well, but I also saw at times if, let's say, the attending physician saw that it was necessary for the patient to stay longer, then that could be, I don't know if discussed is the right term, or so pushed back to the insurance and say like, no, we need the patient, for instance, to stay an extra 5 days because they're not at the level of functionality that is safe for them to be discharged. So in your experience, how successful is that?
It will depend on who's paying. Like which insurance, is it a Medicare, is it a Medicaid? Sometimes it will come back and bite your institution. And when I was still doing inpatient, I would say to the treating team, and I think this is still fair, if I keep that patient X number of days, tell me what you will accomplish, that will matter, right? It's not enough to say, I'll have more range of motion at that ankle, but if you can tell me that transfers will be a min assist, where the patient's, only is doing 75% of it, basically, or you can tell me their fall risk is decreased. But if it's just you want to keep them a few more days because you like them, that's a credibility issue as well for the physician who's requesting the peer-to-peer to get more days, and for the team and for your institution. So it does depend. There are guidelines that that Medicare has put out about how long X diagnosis, right, or diagnoses should be in, and it will depend wherever you practice on how much you feel obligated, or your institution feels obligated to stick to those guidelines. And some hospitals pay attention more than others. It doesn't always make sense. A workers' comp patient who's going to get the care covered, I would be less likely to kick them out because they're going to get covered, and your institution's not going to go broke over that. But the metrics of what's important might be affected. But I, as a physician, try to stay focused on that patient. But again, also my credibility, right? Don't tell me you're going to do whatever with that time if you're really not, and you're just making up excuses. But very often, when you come together, if you're truly a team, you can work on trying to make whatever those identified goals happen.
Right. Yeah, that makes sense. It's good to know that, first of all, that team approach is important, right? Making sure that the increased length of stay comes out with a legitimate goal that is something that can make sense to the insurance. But also, it's interesting to know that it does have negative connotations, because I'm thinking more on the larger scale, the hospital revenue, having more patients rather than one patient stay longer at times seems to be profitable. So it varies if now I can see of like the other layers of complexity that length of stay adds to it. If it's a private equity, if it's a for-profit, if it's a nonprofit hospital, how that can change. Yeah, it's way more complicated than I thought. But
Yeah, it would be nice if it wasn't, right? Wouldn't it be nice if you could just say, I think we can accomplish this, so we're going to keep you another week or 2 or 3.
right.
So when I was a brain injury fellow a million years ago, patients would be in inpatient rehab for 6 months. So
Wow.
think about how that would impact. I mean, these are patients, especially acutely, who are evolving, right? So you're a bigger part of that evolution. Family had a lot more time to adjust as much as possible, to learn how to care for that person, to develop relationships with the treating team, who also had more of a relationship with that patient. Right. And even then, I'm sure that, back then, if I could remember that, 6 months didn't seem like enough. It doesn't happen anymore. They don't stay that long. On rare occasions, they may for different reasons, and then they would still go somewhere else, probably, or they would go home, but they would go home with a better prepared family, maybe more appropriate equipment. Because if you have a patient as an inpatient for like 2-3 weeks during this time of evolution, it's really possible that the equipment that we're gonna to order to get that person home is really not the equipment that they're going to need in 6 months. Or are we holding them back because they're not being able to get more intervention earlier on, right? So it would be nice if we could deliver care based on what each individual patient could access or would benefit from, but that's not very often the main driver.
Right.
We practice very often. This is going to make people not want to go into my field, but we're very often practicing based off of what the contract is, as opposed to what that patient's potential is. To me, that's sad. But you do what you can do, right? Not everybody gets everything, no matter what. But if one more person gives me that Volkswagen versus Mercedes analogy, I may scream. But it is true, but there are certain, at least basics that we hope we can get people. And not every disability is the same, and not every person is the same in so many ways.
Right. It's important to have a realistic view of the field that you're going into. And like you said at the beginning, but
that was nice of you. Thank you for that.
Right. I think it really depends on how you look at it, right? It can come off frustrating, in my opinion, if your heart isn't there. But if you have the bigger goal, which is patient advocacy, which is you, I guess, not fighting for a patient, but truly advocating for your patients, then, for instance, that prior auth paperwork that you need to do, or that the extra talk that you need to have with so-and-so so we can get the care or the equipment that the patient needs, can come or hopefully can be less taxing on you as a physician than if you're just looking at it, man, this is just what I have to do to make it to 5 p.m. so I can go home. So I think having a different mindset toward that can really change your experience, but also that realistic view of, unfortunately, that is part of the contract, right? That's why some physicians choose to go into private practice. Some physicians choose to stay in academic medicine for different reasons. But at least there is so many different varieties that you can pick and choose what works best for you, and what fits your lifestyle.
You never know. The American Academy of PM&R, AAPM&R, sometimes they offer a course, and it's non-clinical career paths for physiatrists. My point in raising that is it's not just necessarily I take care of my patients, I go to the clinic, I go to my office, I go home. There are a host of different ways you can be a physiatrist and still have employment without even necessarily having direct patient care. Just don't become that medical reviewer who denies care.
Right. We wouldn't want that at
No.
all.
That would be such a waste.
So we've chatted a lot about very different things from brain injury, spasticity, but I feel like the overarching theme has been patient advocacy, hearing your patients, be a good human being, and basically how to be a good physiatrist. So what would you say is one advice that you'd like to leave our listeners with, whether they're medical students, young physiatrists who might be interested in spasticity or brain injury, or just regarding patient advocacy in general?
I think I would leave y'all. I've lived in Texas too long. I would leave y'all with a few things. Don't forget why you chose to go to medical school, because I see that happen. And don't forget that could be you or your family member tomorrow in the blink of an eye. I see that happen too. It's not the patients that burn us out. I love patient care. Mostly I love teaching every now and then, but mostly those are things that keep me in it, have kept me in it this long. And then find what part of it makes you feel good. It makes you want to get up in the course of the morning where you don't really want to get out of bed that day and face whatever's coming. Remember those people that you really care about that are your patients or their families, or I think, like I said, that's one of the things that has helped me fight burnout. And when you get burned out, take a really cool vacation. That's another thing. So, but I think my main point will be, think about why you want to be a physician and what you like about being a physician, and then find the niche that rewards you, because it is rewarding. And sometimes I'll forget. I keep my kudos box of letters I've gotten or emails I've gotten from people, and I forget it's there. I should go look at it on those days when I feel burned out. But that's what mattered. And also, I think something that's mattered to me is I mostly like the example I've set for my own family, my kids, who have a good work ethic, who have a lot of empathy for other people, and and know that you have to work hard. It's just is what it is.
Very well said. Medicine is a big empathetic field if you choose for it to be, and maintaining that beginner's mindset, that curiosity that you talked about, is what allows you not to burn out and see every patient for the individual they are. And there's this beautiful book called, you may have heard of it, it's called Attending by Dr. Epstein. It's Attending Medicine, Mindfulness, and Humanity. And he does an amazing job of highlighting that beginner's or that childlike curiosity, basically. Every door you go in, every patient, just be truly and genuinely curious. And that's pretty much how I've tried to navigate my medical school journey. And actually, I said this in one of the other podcasts with Dr. DeCipio, where we talked about OMM. When I first started medical school, my biggest promise to myself was not to lose the fire that I started medical school with. And I'm so proud to say, even though fourth year, managing everything together can be really draining, I've managed to have that passion, that enthusiasm when I talk to patients. And I think a big part of it is for what you mentioned, is to remember that we're making a difference, that we're might be that little glimpse of hope for the patients that we're seeing in that day. And that can carry you very, very far. Those days that you're just feeling down and you're just so over dealing with insurance and everything else.
That is true. That is true. So, well, thank you for asking me to do this. It's always a pleasure to see you.
Of course, likewise. And thank you everyone for listening to this episode. If you have a few seconds, please leave a review on our Spotify or Apple Podcast page and let us know what you'd like to learn about in the future. Until next time.